Imagine you're looking into a surgical procedure, a super common one, and you pull up the medical studies and they completely contradict each other.
Right, like total opposite ends of the spectrum.
Exactly. One study says, this specific patient factor, it has absolutely zero impact on whether the surgery succeeds. But then another study says, wait, no, it actually doubles the failure rate. Welcome to the deep dive, by the way.
Glad to be here. It's a wild topic today.
It really is. We're looking at stress urinary incontinence today, or SUI, which,
Yeah.
affects millions of people. It's when physical exertion or like coughing or sneezing causes urine leakage.
Yeah, and the gold standard treatment for this, the surgical fix, is the mid-urethral sling, the MUS.
Right. Which acts kind of like a tiny hammock, right?
Hmm.
Supporting the urethra. But our mission for this deep dive is to untangle a really specific, really fiercely debated question in the literature.
And that question is, how exactly does obesity impact the long-term failure rate of these sling procedures?
Because, the data is just all over the place.
It's a perfect case study in, well, the danger of static analysis, right?
Right.
You're applying it to a dynamic biological system. If you want to understand the long-term impact, you have to look at the timeline.
So let's start with the short-term stuff, because this is where the mirage really begins. If you just look at, say, the 6 to 12-month follow-ups, obesity doesn't seem to matter at all.
Yeah, in that short-term window, it looks like a mechanical triumph.
It really does. There's this one-year Korean study that analyzed two specific sling variations, the Spark and Monarch procedures, and they looked at clinical outcomes across the entire BMI spectrum.
And what did they find?
Basically a statistical tie. They found no significant difference in cure rates or complications regardless of BMI. The objective cure rate was like 96.2% for normal weight patients and 94% for overweight patients.
Right, which is incredibly high for both.
Yeah. So if you're a surgeon reading that, you're probably thinking, hey, this procedure works for everyone.
You are. Because in that immediate postoperative window, the procedure is functioning exactly as engineered. We have to consider what's actually happening in the pelvis on day one.
Okay, walk us through that.
So the surgeon places a strip of macroporous polypropylene mesh. In the short term, that sling is relying almost entirely on the tensile strength of the synthetic material itself, plus the immediate fibrotic reaction, the scarring that anchors it.
So it's basically just raw mechanical strength at that point.
Exactly. It provides a rigid backstop for the urethra. At 6 months or even a year, the mesh hasn't degraded, the tissue hasn't aged much, and the initial tension is holding perfectly.
It's like propping up a sagging bookshelf with a brand new steel bracket. On day one, whether you put lightweight paperbacks on it or, heavy encyclopedias, the bracket is going to hold.
That's a great analogy. The structural integrity of the bracket of mesh is flawless early on. But the problem with relying on one-year data is that, well, it treats the human body like it's a static architectural structure.
Right, and it's definitely not.
No, not at all. The pelvic floor isn't a wooden beam. It's a living, aging network of muscle and fascia. Researchers often publish one-year data because of, funding cycles and pressure to get results out.
Which totally makes sense from an academic standpoint, but as a patient or a doctor, it's a classic pitfall. Short-term data can completely mask the long-term reality.
It creates a profound false sense of security. Because evaluating a permanent synthetic implant based on just 365 days it's practically an incomplete sentence.
So what happens to that bookshelf, after 5 or 10 years of holding up those heavy encyclopedias? This is where the narrative just fractures.
It really does. This brings us to the downward pressure of time.
Yeah, let's look at the 10-year follow-up study out of Sweden, because they tracked a massive cohort of women a full decade post-operation, and this study flips the script entirely.
Completely flips it. Because at 10 years, a higher BMI at the time of surgery emerges as a definitive, independent risk factor for failure.
The numbers are actually pretty shocking. So a subjective failure at 10 years, it scales directly with weight. If a patient's BMI is under 25, the failure rate is 30%.
Which, just to note, means a 70% success rate. That's still a highly durable outcome for a decade of relief.
Right, absolutely. Yeah. But as the BMI goes up, it gets worse. BMI 25 to 30, the failure rate hits 40%. BMI 30 to 35, it's 47%. And for patients with a BMI of 35 or higher, it's a staggering 59% failure rate.
And patient satisfaction tracks that exact same downward trajectory. I think it's 82% satisfaction for BMI under 30 versus only 63% for BMI over 30.
Yeah. And there's even another study on morbidly obese patients, BMI over 40, showing they're twice as likely to fail long-term compared to normal weight individuals. So why is this happening?
Well, over a 5 to 10-year period, you have tissue remodeling occurring around the tape.
Mm.
The pelvic floor naturally deteriorates. You lose collagen tensile strength.
Like pouring concrete around a living tree root system,
Yeah.
right? Over a decade, the tree grows, it shifts, it puts pressure on things.
Exactly. And in overweight patients, you have this prolonged, elevated intra-abdominal pressure. Every time they stand or walk or cough over that 10-year span, that increased mass is constantly pushing down.
Just relentless downward force.
Relentless. The synthetic tape doesn't stretch, the polypropylene stays intact, but the biological tissue holding it, it slowly yields under the mechanical strain. It eventually counteracts the sling support.
Okay, I have to push back a little here, though. If you're a doctor and you know the failure rate approaches 60% after a decade for a highly obese patient, should you even be offering this surgery to them?
That is the big clinical dilemma, isn't it? Are we just putting them through an invasive surgery to eventually land back at square one?
Exactly. It seems almost counterproductive.
But we have to be careful about how we define failure. A 10-year failure rate doesn't mean it failed on day 2.
Right. It held up for a while.
For a patient with debilitating daily incontinence,
Mhm.
buying 7, 8, or 9 years of near-total symptom relief, that is a massive restoration of quality of life.
Oh, wow. Yeah, when you frame it like that, it's nearly a decade of normalcy.
The clinical failure isn't necessarily doing the surgery. It's failing to manage the expectations. If they expect a permanent lifetime cure, they'll feel like it failed. If they know it's a decade-long management strategy, the calculus changes.
That makes a lot of sense. But digging deeper into the literature here, it seems like we can't just blame gravity and weight. The physical dimensions of the body actually change how the surgery has to be performed.
Right, it's not just physics, it's anatomy. The surgical nuances matter immensely.
I read this and it blew my mind. Obese patients literally have a longer urethral length compared to non-obese patients.
They do, physically longer.
Yeah.
And that variance alters everything in the operating room.
Because surgical techniques are super standardized, right?
Very standardized. Surgeons learn to make the incision and place the tape at a very specific distance to target the mid-urethra. But if you apply a standard geometric blueprint to a non-standard anatomical structure...
The placement is going to be wrong.
Exactly. Because the urethra is elongated, the standard measurement means the tape often ends up in a suboptimal location. It gets anchored too proximal to the bladder neck, rather than the true mid-urethra.
And the data shows that inappropriate sling location is a huge driver of recurrent stress incontinence.
In those cases, it's not failing because of 10 years of tissue degradation. It's mechanically compromised from the moment they leave the OR.
So it's not that the tool is entirely wrong for the job, but the blueprint has to be custom tailored to the specific architecture of the house.
That's a perfect way to put it. Which brings us to the actual surgical approaches, because how you put the sling in makes a massive difference.
Right. There are two main ways to insert this sling. The retrocubic approach, which goes behind the pubic bone, and the transobturator approach, which goes laterally through the thigh area.
And for a long time, broad population studies treated these two as basically interchangeable.
But when you isolate patients with high BMI in a meta-analysis, that equivalency just vanishes. The retropubic approach is actually vastly superior for obese patients.
And it comes entirely down to force vectors.
Walk us through the vectors, because I found this fascinating.
Sure. So the transobturator approach creates this relatively flat horizontal hammock under the urethra.
Okay.
But the retropubic approach creates a vertical circumferential U-shape.
Like dropping vertical suspension cables from a bridge tower versus stringing a horizontal tightrope across a gorge.
Yes. A flat tightrope can't absorb chronic, heavy downward pressure. It just bows and gives way. But vertical cables are structurally engineered to bear and distribute downward loads.
Because they anchor into that rigid retropubic connective tissue, right?
Exactly. It creates a structural backstop against that chronic downward pelvic pressure. The flat hammock of the transobturator route just gets overpowered over time.
So the anatomy really dictates the approach.
You can't just deploy the easiest or most common surgical method. The architecture of the repair has to be bespoke to the biomechanical load.
Okay, so up to this point, the narrative feels really clean. Obesity creates downward pressure, it changes urethral length, and it requires vertical load-bearing surgery.
Closed loop, right.
You would think so, but medical literature rarely allows for narratives that clean.
Enter the hidden variables. Just when we think we solved it, there's a study that completely destabilizes our neat mechanical assumption.
The 58-month follow-up study analyzing transobturator slings.
Yeah, let's talk about this one, because initially it seemed to validate everything we just said. The raw, unadjusted data showed that higher BMI correlated with higher failure rates over 5 years.
But raw correlation is often a trap.
Right. To find the actual cause, the researchers did a multivariate analysis. And for anyone who might be a bit rusty on statistics, a multivariate analysis is basically a mathematical model that lets you observe multiple variables at once while holding certain things constant.
Right, to see what's actually driving the outcome. Like, you might have raw data showing people who carry lighters have higher rates of lung cancer. Strong correlation. But if you hold cigarette smoking constant in your analysis, you realize the lighter didn't cause the cancer. It was just correlated with the real culprit.
And when researchers applied that exact statistical model to these sling failures, the obesity correlation completely flattened out.
Wait, really? So BMI wasn't the cause?
BMI was not the independent variable causing the failures. The hidden variable, the actual clinical culprit, was preoperative mixed urinary incontinence, or MUI.
Mixed urinary incontinence. Okay, break down what that actually means for the patient.
So patients with mixed symptoms have two problems. They have the stress component, the mechanical leak from exertion, coughing, sneezing.
Which the sling fixes.
Right. But they also have an urge component, which is a sudden neurological overactivity of the detrusor muscle in the bladder.
And the data on this is just wild. Obese patients have a vastly higher rate of pre-existing MUI. It was 32.1% for high BMI patients, compared to just 7.5% for normal weight patients.
Because obesity is heavily intertwined with things like systemic inflammation, metabolic syndrome, and pelvic floor neuropathy. All of those exacerbate the neurological urge component.
And the mid-urethral sling, like we established, is purely a mechanical fix.
Yes. It does absolutely nothing for the neurological urge overactivity.
So a third of these high BMI patients go into surgery with both issues. The surgeon fixes the mechanical stress leak perfectly, but the urge issue is totally unresolved.
Exactly. So the patient continues to experience leakage from the urge component, and they report the surgery as a subjective failure.
That is such a classic statistical trap. You see obesity and surgical failure in the same room, and you assume one caused the other. You totally miss the neurological condition hiding in the corner, skewing the data.
It fundamentally changes how we view the risk profile. If an obese patient undergoes testing and they have pure, isolated stress incontinence zero urge component, their probability of long-term success might be dramatically higher than that generalized 59% failure rate we talked about earlier.
Which just highlights how crucial it is to get the right diagnosis before you even touch a scalpel.
Meticulous preoperative phenotyping is just as critical as the surgical technique itself.
Biology is just so complex, it's rarely a simple cause and effect. And speaking of complexity, digging through these studies revealed something really counterintuitive. There's actually a surprising silver lining for obese patients.
Yeah, this is where the biological trade-offs really show up. We spent this whole time discussing how excess tissue degrades the sling's long-term efficacy.
But it turns out that same tissue mass actively defends against one of the worst surgical complications. Let's talk about postoperative mesh exposure.
Right. Mesh exposure is where the synthetic polypropylene tape eventually erodes through the vaginal wall. It's a dreaded complication. It causes pain, infection, and usually requires surgical removal of the mesh.
A 2022 study looked at this. They tracked 120 obese patients and 172 non-obese patients to measure how often this erosion actually happens, and the results completely flipped the mechanical narrative on its head.
The exposure rate in the non-obese group was 8.1%.
And in the obese cohort, it plummeted to just 1.6%.
Which is a massive, statistically significant reduction.
Why does that happen? I mean, how does more weight prevent erosion?
What mesh erosion is fundamentally a friction and tissue ischemia problem. The rigid synthetic tape is resting against the vaginal wall. Over time, physical movement creates microabrasions. If the tissue is thin, the mesh just shears right through it.
But obese patients have a vastly thicker layer of subepithelial tissue.
Exactly. The very same excess mass that creates all that downward pressure, the mass that slowly challenges the sling's tension over a decade, acts as a biological shield.
It's a localized protective buffer. The thickened vaginal wall absorbs the abrasive friction of the mesh so it doesn't erode through.
It perfectly illustrates biological trade-offs. The high BMI environment is incredibly hostile to the biomechanical function of the sling over 10 years. but it is highly protective against the localized tissue trauma of the implant.
A structural detriment in one system is an anatomical shield in another. That's just fascinating.
It really is.
Taking a step back from all the surgical specifics, this entire deep dive really serves as a masterclass in how to read data. I mean, we started with 2 peer-reviewed studies that seem to exist in alternate realities.
One said BMI had no impact. The other said it was the primary driver of failure.
And as a learner, your biggest takeaway here shouldn't just be about urology. It's that both studies were technically accurate within their defined parameters.
Right. The friction between them is where the actual knowledge is. Reading medical data means interrogating the timeline. A 1-year study on a permanent implant isn't enough.
You have to extend the horizon. You have to see how the biology interacts with the intervention over a decade. And you have to hunt for hidden variables, like the mixed incontinence.
Raw correlation is the easiest way to generate a headline. But without multivariate analysis holding those variables constant, you're looking at a statistical mirage.
So next time you see a study declaring a definitive link, ask yourself, over what time frame? And what hidden variables did they fail to isolate? Context is everything.
Interrogating their methodology is the only way to find the clinical truth.
Before we wrap up, I'm going to leave you, the listener, with a final forward-looking thought. Something that wasn't answered in the sources, but feels like the logical endpoint of everything we've talked about.
I think I know where you're going with this.
We've established that the core problem for high BMI patients isn't the immediate surgery. The sling works beautifully on day 1. The failure comes from a decade of tissue remodeling and constant downward pressure.
Right, we're using a static, fixed piece of tape to treat a highly dynamic biological environment. It's an inherent engineering mismatch.
Exactly. The tension set by the surgeon on day 1 is locked in permanently. So why are we accepting static solutions for dynamic problems?
It does seem inevitable that the future of this treatment has to move away from static meshes.
Right. Like imagine a dynamic, adjustable sling. A microimplantable device that doesn't just sit there passively, but can be non-invasively calibrated over time.
As the patient's body mass fluctuates, or as the fascia loses elasticity, you could just externally adjust the sling to dial in the exact tension needed.
To counteract the new downward force vectors.
The biomechanical and material science hurdles for something like that are immense, obviously. But that is exactly the trajectory the field needs to take. Shift from a one-time repair to a living, adjustable support system.
It's just a fascinating concept to mull over. We started out looking for a simple binary answer. Does the surgery work or not?
But the reality is a decades-long negotiation with time, gravity, and biology.
The true measure of medical innovation isn't just whether it holds today, but how well it adapts to the years to come. Thanks for joining us on this deep dive.